Today, Dr. Megan Horton will discuss her current World Trade Center study entitled Risk and Resilience Factors for Adverse Mental and Physical Health Outcomes Related to World Trade Center Exposure. The project examines the experiences of individuals involved in the rescue and recovery efforts following the events of 9/11. Dr. Horton and her team are working to understand how risk and protective factors are associated with disease development, with the goal to identify vulnerable responders and determine which factors may protect against the development or progression of disease, with potentially broader implications for future disaster response and recovery efforts. Dr. Horton is an associate professor in the Department of Environmental Medicine and Public Health at the Icahn School of Medicine at Mount Sinai. She received her MPH and PhD at Columbia University in Environmental Health Science and was a recipient of the prestigious EPA STAR Fellowship during her doctoral studies. Her other research combines state-of-the-art environmental exposure assessment with neuroimaging and behavioral phenotyping to understand how early life exposure to neurotoxicants affects neurodevelopment. Additionally, she investigates how environmental, social, and occupational stressors impact later life health outcomes, including PTSD and cognitive impairment. It really gives me great pleasure to welcome Dr. Horton. The floor is all yours.
As Christy said in the introduction, I'll be talking about the results today of two NIOSH-funded pilots focusing on risk and protective factors for adverse mental and physical health outcomes related to World Trade Center exposure. At Mount Sinai, I'm a member of the Mount Sinai Institute for Exposomic Research, which is a new center that opened its doors several years ago and is one of the first centers of its kind that's focused on bringing together a transdisciplinary team of researchers and expertise to develop analytical and statistical methodologies to address exposomics. Exposomics is a term that was defined by Christopher Wilde in about 15 years ago to understand the study of how all environmental factors interact with your body throughout your lifespan to affect your disease risk. So critical to the study of the exposomics is that it's very complementary to the Human Genome Project or to the understanding of genomic risk and what we carry in our genes and how that influences disease risk. It's the environmental complement. So it's understanding how external and internal factors in our environment, so things like diet, infection, pollution, exposure to toxic chemicals, etc., combine with other factors such as our life stage, factors like our body weight, and other things interact to impact our overall health. The premise for this work is from considerable research demonstrating that the environment plays a role in the development of every disease. And this is a slide pulled from an article published by Rappaport et al. in 2016, looking at the contribution of the environment versus genetics in many common diseases. So in things like leukemia, it's estimated that 90% of the burden of leukemia comes from the environment and only 5% from genetics. Parkinson's is similar, with about 90% of the contribution attributed to environmental exposures and 10% attributed to genetics. So it was this understanding that many diseases have a strong environmental component along with a genetic component that drive exposomic research so that we can look at how the environment and genes interact for disease risk. At the Institute, we've developed several cutting-edge methodologies, and we could give a talk about each one of these different aspects, from exposure technologies to the development of wearables, some of the work that Alan Just and his team are doing in satellite analysis. But today I'll focus on some of the methods that we're using to analyze this high-dimensional data that's coming out of these new ways to look at high-dimensional exposures, as well as multifactorial diseases. So I'll focus most of the talk today on work that we're doing leveraging a statistical method called weighted quantile sum regression, or WQS regression. This method was developed almost a decade ago by Dr. Chris Jennings, who's our director for biostatistics in our department at Mount Sinai. And what Chris and her team were really interested in doing is understanding how a mixture of chemicals, not just a single chemical, can be associated with a health outcome. And in particular, Chris was interested in how to try to look at chemicals that may be highly correlated can be looked at, can be examined together in a mixture, and then to backtrack and see if we can disentangle some of that correlation and look and see what might be the most impactful or the bad actors or the good actors in that mixture as they're associated with health. So I hope you can see my pointer, but what WQS does is take this mixture of exposures. So here I have exposure 1, exposure 2, exposure 3, all the way up to exposure N. So we've put in some models up to several hundred exposures or features into a model, and develop an index based on that model, and then examine the association between that index and the health outcome. So the first step in the WQS is to score the combined components into this index. And to do that, we determine the empirical weight of each individual exposure as it's associated with the outcome using a nonlinear regression with the bootstrap. So we look at the association between exposure 1 and the health outcome, exposure 2 and the health outcome, and exposure 3 and the health outcome, and then combine those weights together into a WQS index that still holds on to the individual weight of each one of those exposures. We constrain this index to sum to 1 and confine it to 0 to 1. And this allows us to see if that index in our model is significantly associated with the health outcome. We can backtrack and see what is the contribution of each one of those individual features in the mixture. So we can see, is it, for example, if we're looking at a mixture of lead, manganese, and zinc, can we look and see whether the powerful effect is coming from lead or from zinc or from manganese, or is it from a real contribution of all of those? One of the other main strengths of taking a WQS approach is that we can look in both the positive and the negative direction. So we can look to see whether our mixture is associated with an increase in the health outcome. So is it a negative health effect, or we can look to see whether there's a reduction in the risk of that health outcome. So we can look both in the positive and the negative direction. Since the first WQS methods paper was published in 2014, there have been over 350 papers published using this statistical approach to examine associations, mostly between chemical mixtures and health outcomes. So I just pulled this out of the PubMed to show the increasing number of publications that are using WQS and new extensions of WQS to address this growing question of exposomic exposures or mixtures of many chemicals and how they impact health. I just pulled an example that Elza Reckman, who is one of the postdocs who worked on this NIOSH-funded pilot, where she built a lot of her expertise was looking at using WQS to look at mixtures of multiple metals and visual spatial learning in adolescents. So topically, this is a little bit less relevant, but statistically, it's using the same methods that we're using in the pilot. So I wanted to bring it up. So what we're looking at in this paper is working memory errors and the WQS mixture. And so in this, she combined a mixture of multiple metals and ranked those, the quantiles. She used 10 quantiles. So she was looking at how that WQS mixture was associated with increases in working memory errors. And here we're plotting the beta of that association between the WQS mixture and working memory errors. And we can see that there's an increasing slope. So in this model, the higher your burden of exposure to metals, the increased number of working memory errors that you make. When you do have this positive association or significant association between the mixture and the outcome, you can look at the weights and try to interpret which of the weights or which of those metals in that mixture are the heavy hitters in this association. And in this paper, we showed that the metal mixture was associated with increased working memory errors, and that the association seemed to be due to exposure to copper, manganese, and lead. So I just highlight this as an example of how this statistical method can be used to look at a mixture of correlated compounds and a health effect. This paper was published in 2020, coming out of Dr. Roz Wright's lab here at Mount Sinai. And this was a new application of the WQS that I hadn't seen before and really prompted a lot of our thoughts about this project that we did in World Trade Center Responders. This was one of the first papers that I saw that used WQS to look at a mixture of non-chemical exposure. So this was looking at trying to disentangle associations between maternal stress, psychological functioning, and race and ethnicity on infant negative affectivity at 6 months. So it was a new application of the WQS. So they combined in this study, they looked at lifetime stress, negative life events during pregnancy using the crisis, depressive symptoms and PTSD symptoms in women during their pregnancy, and how those impacted infant negativity. So again, we're looking at in the diagram, in the plot, we're looking at the WQS index on the x-axis, so increasing exposure to these negative life events or these stressful events was associated with increased negative affectivity in the infants. And then what they did in this model was stratify to see whether they could see how that association between stressful life events and infant negativity differed by race or ethnicity. So it was this model of looking at non-chemical mixtures that made us think, wow, what can we do with the World Trade Center that might take into account some more of the data that's available through the data center. And so that prompted this idea of the development of a WTC exposome. So we know that the World Trade Center exposure is a complex mixture. It contains chemical toxicants, lead, arsenic, chromium, manganese, etc. There's exposure to particulate matter, to smoke, dust, and debris, traumatic stressors, unsafe environments. So how could we combine the WTC-related experience that encompassed the mental and physical health status, and also the socioeconomic status and social support at the time of 9/11 to look at this WTC exposome? And this was the figure that sort of brought our thoughts on paper. And as it relates to the figure that I showed before of the exposome, thinking about external factors and internal factors, and how can these combine to better understand the experience of a World Trade Center responder at baseline, and how we may be able to use that to see who's at greater risk for some of the WTC related conditions and who's at less risk. What are some of the factors that seem to be protective or instill some resilience in these responders? So the overall aim of the pilot study that was funded by NIOSH was to model a WTC exposome and determine the harmful and protective associations between this exposome and WTC certified risks, and then to look at some of the emerging WTC related conditions. We're certainly building on over a decade of incredible work demonstrating strong associations between World Trade Center exposure and health-related outcomes. And we rely constantly on the paper written in 2011 by Juan Wisniewski, who looked at questions that were available in the exposure assessment questionnaire, the EAQ, which was administered at baseline. And using several questions from that exposure assessment questionnaire, this group categorized exposure into low, intermediate, high, and very high, based on the total time that the responders spent at the site, whether they were directly immersed in the cloud, and whether or not they worked on the pile. So in this study, they looked at almost 30,000 of the responders in the World Trade Center Health Program, and saw that responders who had high and very high exposure to World Trade Center had an increased incidence of multiple health outcomes, or many health outcomes, including asthma, sinusitis, and gastroesophageal reflux, or GERD. And so this was really the premise of saying there's something to this. There's certainly a strong association, but what else is there? What else could be going on that may increase the risk or may instill some protection against outcomes? In addition to this work, there's several papers showing associations between World Trade Center exposure and related health outcomes, many of which you all published. And the majority of this work is taking one or two of the questions from the EAQ or from the surveillance data set, breaking it into categories, and then looking at those associations. So I mentioned already the Wisniewski paper. This is a paper, this second line is looking at whether or not individuals were in the dust cloud, whether they worked on the pile, breaking it down into 3 groups and looking at elevated heart disease risk, Sometimes the exposure is broken down into two groups. Several studies have looked at World Trade Center risk as time of arrival on the pile, and whether or not being down there when the cloud was very intense, and how that was associated with increased risk. So there was certainly a premise for this work based on prior work, and we wanted to get into disentangle this just a little bit more to see what else did we know about these responders. I also want to say that there are several studies already published looking at possible protective factors. Catherine Wheeler and her group published a paper looking at asthma diagnosis and demonstrated that within the group they were looking at use of a respirator protected against developing WTC-related asthma after the tragedy. Elza and I published a paper several years ago looking how respirator use also protected against changes in white matter microstructure or actual structure in the brain. So World Trade Center responders who reported using a respirator had less impact or less association between changes in white matter. And Adriana Feder and her group have also published several studies looking at the association in the of World Trade Center exposure with PTSD risk, and shown that several factors can be protective against PTSD risk, including things like whether or not an individual felt that they were supported at their workplace, whether they had a supportive home life, and also other factors that could protect against disease risk. So this again supported that there may be factors that are increasing risk and factors that decrease risk, and that we thought WQS was an ideal tool to try to disentangle this. So what did we actually do in this study? We started out, as many pilots do, very ambitiously. And I have to acknowledge our work. We worked very closely with the World Trade Center data center, including Christopher Hahn, who really helped us understand the variables in the surveillance data set and recode them. So our plan initially was to try to pull questions from the entire visit that was administered at baseline. So over 3,000 different variables, from the exposure assessment questionnaire, which has 660 variables. What can we look at from the physical exam, pulmonary function tests, the SAM-HQ, which talks about mental health outcomes, etc. So we looked at all these questions and still have some goals of including more aspects into our exposome. But for right now, we focused, and the data that I'll be presenting today is focusing mostly on what items we could pull from the exposure assessment questionnaire. So what we did with the exposure questionnaire is pull all variables that we could that were not repetitive and that were prevalent in at least 10% of the population. And critical in the WQS approach is that we have to rank every variable in a similar fashion. They have to have a homogeneous rank so that when we put them into the index and try to backtrack and see that they're all ranked similarly. So it's not as though we have variables that are switched, where the highest ranking is a negative effect versus if the highest ranking were a protective effect. We switch everything so that it's dichotomized, 0 meaning absence or null and 1 meaning presence. And we put all of those measures into the index. For variables in the EAQ that were not already categorical, we looked at the distribution. So for some continuous variables or ones that had categorical distributions with multiple levels, we looked at the distribution and usually categorized by the median, although for some we categorized by the quartile, depending on the, again, the distribution. From that work, we narrowed down the EAQ to about 85 independent variables. And I know that it's impossible for you to see the letters on the left side, but basically these are all of the factors that we included in our exposome related to different groups. So things like exposure to dust. So that's ranked as yes is 1, exposure to dust during their rescue and recovery efforts, exposure to noise, mold, sewage, etc. We looked at occupation, whether they were in construction, where they were in law enforcement, etc. We looked at their location, whether they were in the pile, whether they were on the periphery, and the timing of their exposure, whether they were there within the first few days and then within the first month, and also things like how long were they there, and other experiences, such as did they sleep on the site? Did they experience the trauma of family members? And those are mainly the categories that fell into this 85 or so variables that we included in the model. The outcomes of interest for the purpose of this grant, we focused on several WTC certified conditions and then emerging conditions. So we looked at the PCL scores along with Chris to pull out those subjects that had been diagnosed with PTSD. We looked at diabetes, GERD, respiratory diseases, combining asthma and both upper and lower respiratory outcomes, and then emerging conditions such as headaches, which required a little bit of coding to see whether responders were reporting having headaches, but that's not a currently certified condition. So I'll put up the graphic again of the WQS. And as I said before, the WQS allows us to look on the far left of the combination of each one of these individual factors or features and combine them into the index to look at the health outcome. If we modify this slide to relate to our WTC, we put all of those 83 or 85 factors into our index and looked at that index with each one of those individual WTC related health outcomes. So we performed, I guess that's 5 different regressions looking at each one of those outcomes. And then we repeated it looking both in the positive and the negative direction. So we could see which one of these factors were protective and which one of these may increase the risk. Models at this point are all controlled for age at 9/11, gender, education at 9/11, and race and ethnicity. And there are several other sensitivity analyses that we can discuss to try to look at other factors that we should use as control variables. So as you know, many of you know that there are about 47,000 responders in the World Trade Center Health Program in the general responders cohort. Many of them did not consent to having their research or having their data used in research. And so we excluded those, and we excluded those that didn't have complete data. So our final data set for most of our analyses is about 34,000 responders. We thought this was pretty interesting because many of the research studies look at associations between WTC health outcomes within a single clinic. And this is a study that combined all of the responders from all of the different clinics. And this is just a little graphic demonstrating where each one is coming from. And as many of you know that the education levels and race and ethnicity and experience of the responders changes significantly by the clinic. So one of the sensitivity analyses we want to do in the future is look and see if these associations differ by clinic site. Another interesting thing that came out of our preliminary analyses or just understanding the data was comorbidity. So what is it? So we looked at these 5 different health outcomes, and then this is called an upset plot, where we're looking to see how are these outcomes comorbid in subjects. So the way we look at this is these are disease intersections where the number of subjects who have a combination of these or comorbidities among these. So in this first column, we're just looking at subjects who reported headaches and only headaches without any comorbidities. So there's about 6,500 responders in our cohort who reported headaches. In the second column, the way you look at this is who had headaches, respiratory disorders, and GERD. And you can see that almost 5,000 responders had those in combination. So you can go through the line of this to see, is there some logic to how these diseases are combining together or not, which are separate and unlikely to be comorbid. So that was one of the cool things that came out of this preliminary data. And one of the ways that we're trying to look at eventually not just single diseases, but risk factors for comorbidities and how these align together. So the main results from some of the 5 different WQS models run in both the positive and the negative direction. So we can do this either looking at the plots like we did from Elsa's paper, looking at the adolescents, or we can just look at the betas, the confidence intervals. And so to break this down, we're looking at the 5 different diseases. On the top in the reddish is risk factors, and in the blue is the protective factors, and these are the betas with the confidence intervals. So you can see for all of the models that we looked at, we see strong associations between increasing exposure to WTC in the positive direction and a strong association with increased disease risk or increased risk for all 5 of the diseases all 5 of the health outcomes we're interested in. And all are strongly positive, strongly significant. Probably because we're looking at a very large sample size. So again, we have about 34,000 people in each one of these analyses. And so I want to disentangle this a little bit, and we're still figuring out on how to visualize this because it's not easy. So don't try to digest this whole plot at once, because I understand that it's very hard to plot what we're looking at. But this is the same list of 80 some variables on the left, and we're looking at the weight. So we saw significant associations between the WTC exposome as a mixture and each one of those health outcomes. So what we're doing here is plotting those weights. What is it that's contributing most strongly to that association, broken down by disease? So diabetes, GERD, headaches, PTSD, and respiratory outcomes. And in the red are those factors that seem to be increasing the risk, and in the blue, those factors that seem to be protecting. So if you just blur your eyes a little bit and look, you can see that some of the risk factors seem to be the same, but some seem to be very different, and same with protective factors, particularly between the diseases that we're looking at. So one way that we can look at this is just try to break it down to what factors are the highest ranking in the positive direction and what are the highest ranking in the negative direction. So here we're looking at risk factors. So risk factors for those 5 diseases, and breaking it down to what are some of the heavy hitters across the board. So consistently, we see things like whether a responder was working in an enclosed or contaminated area. That seems to be strongly associated, or that seems to be one of the strongest contributors in the association between the exposome and the health outcome for all the health outcomes. Whether they are exposed to blood or bodily fluids, human remains, and whether they worked at construction as an occupation. Though I give one caveat that this is very different when we look at diabetes versus the other 4 health outcomes. So it seems to be that working at construction, or reporting working at construction at the time of 9/11 was protective against diabetes, but an increased risk for some of the other health outcomes. We can switch this and look at the protective factors. So what were the features in the mixture that seemed to be most protective of developing that health outcome? And it's interesting that these are different factors. Some of which we've seen in the other studies that have been published on risk and resilience factors. So one of the things that seems to be protective is working in rescue and recovery activity in the perimeter, so not necessarily on the pile, and that's protective. Interestingly, whether you were retired at visit 1 or employed at visit 1 could either be protective or it could increase your risk. So whether you're retired at visit 1 seems to be protective of your diabetes risk and headaches, but maybe a risk factor or associated with PTSD. If the majority of the shift was not on the pile, it seems to be protective. Reporting of working in protective services or the military, and also having a supervisory role, are pretty consistently protective against developing World Trade Center related conditions. Another way we can look at this is just look at how the distribution changes within a disease. And so you can see those that are ranking in the risk factors in the red versus what are looking in the blue. And how does that compare? We're particularly interested in looking at diseases, comparing the diseases or the profile of risk and protective factors between diseases like diabetes and PTSD, and seeing that there seem to be few similarities between risk factors for these 2 diseases. And so this relates to the upset plot that we saw before, that there is less comorbidity between those subjects with PTSD and diabetes, but more comorbidity between PTSD and something like headaches or respiratory outcomes. So how can understanding this help us understand what sort of profile sets a person up for a particular health outcome, and how can we start to use this in clinical practice to understand who's more at risk and who could perhaps use some additional surveillance during their regular visits. So the next step for this pilot are to continue coding the internal factors. So we really looked mostly at external factors that were associated with the EAQ, but how does a responder's mental health status and physiological status at the time of 9/11 impact their health-related status? And how do these factors, the internal and external factors, interact to improve or increase risk? We have ideas for several sensitivity analyses or stratified analyses looking at how these associations differ by gender, how these may differ by race and ethnicity. As I mentioned, looking at them by site where they're followed up. And another main piece that we're thinking about is what has happened to them post 9/11 that may be impacting their health outcome. So what data can we extract from their longitudinal surveillance data that may help us understand and better identify those more at risk? And again, looking at focusing on those comorbidities. So I'm switching gears a little bit to talk about another application of WQS, which we think is pretty cool and novel, and getting towards that understanding of exposomics and neuroexposomics. So this is work resulting from another NIH pilot funded study that was initiated by Ben Luft and Sean Clouston at SBU, along with Roberto Lucchini when he was here at Mount Sinai, to look at brain changes in World Trade Center responders who had PTSD and or cognitive impairment. So Azura Invernizzi, who joined my lab a couple years ago, brought in some pretty cool tools looking at graph theory analysis to understand patterns of the brain at rest and how those may be associated with World Trade Center exposure. And so I wanted to walk you through this example, how she used WQS to start to think about and understand what's happening in the brain of these World Trade Center responders with PTSD. So in this study, we enrolled just about 100 World Trade Center responders, half of whom had PTSD and half of whom who did not have PTSD. And it was a matched study by age, sex, and education. Most of these responders came from the Stony Brook site and came down to Mount Sinai for imaging. They participated in a multimodal battery or multimodal protocol that included structural and functional. And we'll focus today on the resting state acquisition, which is when we just ask the responders to stay in the scanner at rest and daydream. They have a fixation in a screen in front of them, and they're just asked to sort of space out, not focus on anything, and daydream, so we can look at the activation and connection between areas of their brain at rest. Azura uses graph theory analysis to calculate eigenvector centrality in 111 different brain areas and look at connectivity between these different and activation between these different brain areas. So briefly, eigenvector centrality can be defined as how central a node is. So you can define nodes, each one of those brain areas as a node, and the edges on the path connecting those nodes. So in this graphic, the first node has the highest eigenvector centrality because it's connected to both of them, as opposed to 2 or 3, which are just connected individually to node 1. As this gets more complicated, you can see that node 4 is more highly connected to more different nodes, and also those nodes are connected to other nodes. So the most relevant example that I've heard of understanding eigenvector centrality is thinking about airport hubs. So places such as New York City, which is an international hub that flies internationally as well as nationally and locally, would be considered having high eigenvector centrality compared to a town like Omaha, where I grew up, which is not an international hub and only has a few lines that get it to an international hub. So Omaha compared to New York City, JFK would have considerably lower eigenvector centrality. And this is a way of understanding activation and functional connectivity in the brain. So what we did is use a partial least squares discriminant analysis. This is along with Paul Curtin, who's a statistician here at Mount Sinai. And this models the divergence or the difference in those eigenvector centrality values in those 111 regions from an atlas, comparing the connectivity or comparing the centrality between World Trade Center responders with and without PTSD. And just looking at that eigenvector centrality, Azura and Paul were able to differentiate or identify predictively responders with PTSD compared to responders without PTSD at about 75% accuracy. So this is pretty impressive. This is a fairly small sample size, so it's 45 versus 46 or so, and you can see that that there is this. This is plotting the PLA, looking at the factors discriminating these two groups. We used permutation analysis to understand what were the hubs that were different or that differentiated PTSD versus non-PTSD in this World Trade Center cohort. And so these are the brain areas that differed between the WTC and the non-WTC. And these are aligned with what we've seen in the literature, particularly changes in the hippocampus and in the amygdala. So this is confirming what we know in the literature and also revealing some information about a novel way of looking at the brain. The WQS example that I think is pretty novel is trying to understand, were these hubs in these areas in the brain that seem to be associated with World Trade Center WTC versus non, were these associated with any of the PTSD symptoms? So PTSD is a multi-symptom disorder that has several different symptoms, such as avoidance, re-experiencing, changes in mood and cognition, hyperarousal. These are some of the questions that are asked in the PCL and also in the diagnostic criteria for identifying PTSD. And so, and some subjects come in with all these symptoms heightened across the board, but many come in with heightened experiences in one symptom versus another. And we really wanted to understand, was the PTSD that World Trade Center responders experiencing similar or dissimilar to PTSD in the literature? And so what Azura did is use our WQS model to determine possible associations between the eigenvector values in those functional hubs and PTSD symptoms. So she used the dimensional scales of PTSD and put those into the WTC, the WQS index, to look at the association. So this is, again, as we looked before, this is the mixture index. So keep in mind here, the mixture is the mixture here is composed of the scales of each one of those 4 different symptoms of PTSD. So we're looking at, if you have more of those symptoms of PTSD, then you have decreased centrality in the parahippocampal gyrus. And as this association was significant, we could backtrack and see what symptom seems most to be driving that association between PTSD and brain changes. And we saw that in this association, it was the avoidance symptoms. We also looked at the WQS index of symptom scores and activation or eigenvector centrality in the brainstem, and saw that this was driven more by hyperarousal symptoms. So this is trying to get at understanding mechanisms of PTSD and the association between PTSD diagnosis and brain changes and those symptoms. So I will note that none of these functional hubs survived a correction for multiple comparisons, but it is a suggestion that there's something going on relating brain changes in specific areas of the brain with specific PTSD symptomology. So we thought this was a very novel approach to trying to understand brain behavior relationships using a WQS approach. So with that, I'll conclude and thank particularly Azura and Elza and Paul Curtin, who's the statistician on this, as well as a shout out to Chris Hahn, who really helped with and hopefully will continue to help in the future with the recoding and understanding of the WTC health program surveillance data. And I'll thank our funders at NIOSH and of course the participants and the rest of the research team. And thank you all for participating, and I'm happy to take any questions if there's time.
Thank you so much, Dr. Horton, for this amazing presentation.